Thank you all for being here. Please, again, just as orientation, your name and specialty, what one question you have. We're monitoring the chats. And if you're in the room with other staff, please list all the names. Recognize that I want you, from a food is medicine perspective, to starve your distractions, feed your focus. We got 2 hours. We'll break it around 12 just for a few minutes stretch break. But certainly, if you need to take care of your body, do so anytime. This is going to be recorded. The more you put in, the more you're going to get out. We hope this will be fun. Recognize there will be CME. We're just working the back end on the CME stuff. So we will be marked. Your attendance will be important, and your completion of the survey at the end will be your way of getting CME. And it's not just CME, it's also CEUs for the behaviorists, for the RDs, etc. I'm just going to formally welcome you all again. You're here for All In's Recipe for Health, using food as medicine in the exam room. This is session 3. And I am Stephen Chen. I'm the Chief Medical Officer. I'm going to introduce Daphne Miller. Dr. Miller, do you want to say a quick word?
It's great to be here for the 3rd session. I'm really looking forward to this. And as much as you guys can participate, even turn on your cameras, join in when we have discussions, the more lively and fun it will be. I know that the online format is feeling a little painful for some of you, but the more we can make this a group effort, the better.
Thank you so much. So thank you, Adrienne. Here we go. We had to readjust our educational objectives because the CME team needs us to kind of come up with separate objectives each time. Originally, I'd given you guys the standard objectives, and we're going to kind of dive in and return to these objectives each time. So you're going to see a few different here. The overall objective remains the same. Increase your skillful use of food as medicine to treat, prevent, and reverse chronic disease in a one-on-one clinical encounter. And what we're going to cover today, and sorry, forgive me if there's little pauses because people are trying to come in, so I have to just pause to bring them in. We're going to go back to this piece. Describe 3 pragmatic approaches: when to eat, what to eat, how to eat, to lower insulin resistance, and it should say inflammation as well. And the second one, so we've talked about that, so there shouldn't be anything new. The second one is describe the 6 steps on the spectrum of nutrition interventions that are likely to produce health benefits. The third one is understand and use 2 elements of time-restricted eating to reduce insulin resistance, and utilize 3 elements of mindful eating to address hunger and satiety when making nutrition recommendations. And then the final one is utilize 2 elements related to meal consumption to improve health. So let's jump in. Do you want to go through the case, Dr. Miller?
I would be delighted to. I'm just going to remind you that this is Mrs. C, who's 48 years old, who came to you saying that she really wanted your help addressing her knee pain and her belly discomfort, and especially the fact that she felt incredibly bloated after she ate in the evening. She also had what she considered to be a bit of a mysterious weight gain since moving to the US from Mexico about 7 years ago. She said she's moving a lot during her day, and yet she's gaining weight. And then she asked you to recommend a diet for her at some point. So we went through this the last 2 times, and you all astutely realized that you were not going to recommend a diet for Mrs. C without really hearing what she wanted to eat, and realizing that what you really wanted to do was work within her preferences and maybe recommend some removing or replacing specific items. So I'll next slide.
So you all remember this progression, right? We are tying the multiple inputs from our food environment from the baked goods, the processed carbs, to the fructose pathway, as well as seed oil pathways that impact our body in different areas, from the skeletal, adipose, and liver, direct hits on the liver, that really have this twin engine of hurt, insulin resistance and inflammation, which really ultimately produces a lot of the things that we see in primary care altogether, all of this stuff. Now, this is that piece that Dr. Miller was talking about, right? Part of this beginning is always a little review, just to kind of get to reset where we're at. And the key takeaway from last time was, what did you eat yesterday? Pick a day of the week that they can remember, because 24-hour recalls are not always accurate, but if you can center it on or locate it in one specific day, it can help. And then walk me through from start to end. And so you'll remember, I mean, I'm going to quickly go through some of this, but the breakfast, lunch, and dinner, there's a bunch of things. And we're going to look again at this. But just as a reminder, there's a dessert, and then there's snacks, right? This is kind of a typical day for many people. Now, I do want to then ask the question, and I know folks are continuing to join, which is great. We have 25 people here. So this, in terms of our overall structure, when you walk away from this training, we want you to take away this approach. And this is really, we call it a spectrum of 6 steps. Last time we called it 7, but we kind of worked one of the 7th ones into the 6, and you'll see how, so that it can be used as a menu when you work with your patients, and really more from a motivational interviewing approach. And so one way to think about it is the when, what, and how levers of food and drink. And then there's these actual steps, some with a lot of evidence, some maybe not as much or still emerging. I want to ask the team as a thought question, what were those 6 steps? You got 15 minutes in clinic. You're going to try one of these steps on because your patient wants to try it. Feel free to chat away or to talk into the microphone or show your face. We'd love to see you all. We're going to revisit this slide. You don't have to remember it, but the idea is if it's not coming quickly, that's work for us to continue to do, and that's to take this case-based approach. Have you all remember? Does anybody want to try on one? There's no wrong answer here. Just everyone just kind of practicing active learning. Okay, this is good. There's a blank. So the first, I'm just going to show the whole thing. What to eat, when to eat, how to eat. Erica's right. Erica threw in decreasing intake of sugary drinks. That's like the simplest first step. Not simple always with our patients, but if you want to try something on in clinic this afternoon, you're like, gosh, I want to try a food-based approach. Let's try the remove sugary drinks and alcohol and replace the water, coffee, and tea, right? We're going to go through reminders of these, but there's these 6 steps. We covered in the last 2 sessions, number 1, number 2, remove processed carbs, replacing with veggies, legumes, pulses, and whole grains. And then we closed out, we were really getting close to finishing number 3. This is the big one. I reformatted this, Dr. Miller and I reformatted number 3 to just kind of make it a one-liner. But the basic pathway is similar. Remove the processed stuff, the processed meats, fats, and maybe excess salt. Replace with unprocessed meats, fats, and spices for taste. And the idea is that it's about making the veggies tasty, but it's also for folks who just want to eat the meat for their own sake, not because of veggies being tasty, that these unprocessed meats, fats, and spices together can be tasty. So we're gonna restart today at number 3. We will quickly show you 1 and 2 just to spark the memory. We're going to get into number 4. This is to shorten the eating window and frequency of eating, essentially what we've heard around time-restricted eating. And then mindful eating, the 3 C's, what are those? We'll learn about that, and hunger, satiety, and portion size. If we can get to it, depending on all the questions and whatnot, minimizing meals out and maximizing meals in. This is your basic architecture. When you're in clinic, you're thinking, does my patient want to focus more on the what to eat, or maybe the when to eat, or maybe the how? Every patient's a little different. Within each of these large categories, you have a discrete tactical steps you can take. All right, so we are going to keep on moving. So this is some of the review. We're going to blow through some of the review here. Hopefully you remember this jogs your memory. Step one, just like Erica said, remove sugary drinks, alcohol. Remember that hit on the fructose to the liver and insulin resistance. Replace it with what? Water, teas, and coffee. That's all here in this picture. Number two, you saw this from last time. Remove the processed carbs, the stuff here on the right, the goodies, right? And you place them with the veggies, the legumes, the pulses, the whole grains. And you really want to get familiar with these, right? Because patients, if you just say, I just eat more veggies. So well, sure, doc, well, what do you mean? Or nurse practitioner, what do you mean? And yeah, cut out the refined carbs. Well, what does that mean? People don't know that white rice is necessarily refined carbs, right? So as part of our layered approach to learning and revisiting key steps so that you can hardwire this in your brain, I'm going to add a little more data and information. So for the second step, the number of servings actually matters. The more vegetable and fruit intake, the fewer deaths. This is an important graph that shows that. But the takeaway is, as you increase your fruit and vegetable servings a day, your risk of all-cause death drops down. So this curve, and this is kind of the middle curve. So when I start at 1 or 0, I'm up here. At 1, I'm dropping down 2, all the way down to 5. It starts to level out. In looking at this study, the idea and the conclusions were combining this study with some other work from the Union of Concerned Scientists at a population health level is if an increase of 1 serving of fruit and vegetables per day decreases all-cause mortality by 5%. So if you're up to 5 a day, you're reducing all-cause mortality by 25%. Then it starts to level off. At a population health level, if every person in the US just increased 1 serving of fruit and vegetables, that's 30,000 lives potentially saved. So this is the piece where food is medicine and can be used as medicine.
So just to jump in here for a second, if you don't mind, Stephen, I'd love to get your thoughts on why we're seeing this data. Why is it that fruits and vegetables are actually associated with better, with more longevity and better health outcomes? We've all been taught they're good for us, but what are some thoughts that people have? They're high in fiber, Ronald says. Yes, and so what does that do? It lowers cholesterol, Ronald says, and someone else, let me just see, there's lots of, they're anti-inflammatory. Wow, you guys are all hitting it here. A good source of fiber, decreasing intake of sugary drinks and high carb items. So that is, or that was a comment to somebody else. But yeah, so probably they're great for you for all the things that they do offer that are mentioned here, because like the fiber and antioxidants and so on. But they're also great for you for all the things you don't eat when you have a lot of vegetables, because the fiber increases satiety. So you're less likely to eat some of the unhealthful stuff. So that's how I sort of think of them, as a positive thing, but also a placeholder preventing some of the negative stuff.
And you may recall that what I was trying to give in terms of an image last time around fiber, that the fruit is protected in a sense, or is not protected, but is surrounded by fiber. And so when we eat that and it goes into our GI system, our gastrointestinal system, at that early part of the gastrointestinal system called the jejunum, that's when the sugar gets released and usually taken into our bodies really quickly if I just ate a donut. But because of the fiber around the veggies, it slowly releases that, and it's just a much slower, more gradual. And then the fiber, so it kind of blunts the insulin, the sugar spike and the subsequent insulin spike, and it feeds all that bacteria in our body. So those are some of the other pieces, but absolutely, there's all these benefits. So the next slide just shows, well, what do we mean by a serving? right? That last study said a serving. So what is a serving? What's a serving of vegetables and fruit? And then, yeah, does anyone know? Like, we talk about servings, but actually, how do we quantify it? So technically, we would say a serving is a cup of leafy vegetables or a half cup of cooked or dense veggies. So a cup of leafy vegetables or a half cup of cooked veggies. Question is, how do you talk about this with patients? If you're going to be dosing your patients with metformin, you talk about milligrams, you talk about pills. If you're dosing your patients with food or with vegetables and fruit, and you talk about servings, what do they say to you? Do you use the word serving? What's an easier way for folks to understand this? Thoughts, questions, reactions to that? Hand method. Sangeetha, can you say more about the hand method? Mila talks about the measured amount of food or drink compared to serving to a cup. So people have talked about the hand or a cup. I'm just going to say, for me, I often use fists or I'll use a cup, depending on who, right? There's the palm size quantity. So, and I often, when I'm working with families as a family doc, I'll say, everyone put your fist up because, mama's hand is bigger than the little kid's hand, right? So let's just use our fists as a semblance of this serving. And if it's fresh vegetables and it's a fist, and if it's cooked, you get a little extra in there. But I don't even go through the details of that necessarily because I'm just trying to make it easy. Does it have to be 5 fists or 5 cups or 6 or whatever? No, I'm just starting with the patients and I'm saying, hey, let's look at how many fists or cups you're looking at. And there's just simple ways of showing that. If you want to use the cup method, there. If you want to use the hand or the fist down here or the palm, like others have said, go for it, right? So as a way to operationalize these ideas in clinic, we're just trying to make it translatable to our patients. So moving on then, again, this is step 2, right? We're still talking about veggies here, but a layered effect. There is some information just to show that maybe it matters that we should prioritize types of veggies and fruit. Now, there's some studies that have been put together that basically say, hey, if you get more leafy veggies, more leafy greens, compared to say just random greens, that there might be a nice effect on diabetes and heart disease and stroke. And they're dosing it at around even just 1 serving. So very consistent with earlier studies. Fruit is okay, but just recognize for some patients, the total fructose level can be a concern. But in general, fruit is fine because of the fiber effect if it's whole fruit. So then we get to this removing of the processed meat. So just moving on, just reminders. So it should be straightforward. Replacing with the unprocessed meats and seafood. So no additional work, no additional kind of information to share there. We also talked about another set form of processed fats and replacing with whole food forms. Dr. Miller was talking about veggie dressings, and so I put that in this time. But this is your typical, you get a lot of kind of unhealthy saturated fats, as opposed to more healthy. You can have saturated fats here, monounsaturated fats, all of that, right? But the whole food is here on the right. We talked about the evolving data on saturated fats, and the key point was if it's a whole food that has saturated fat, that's different than the processed food with saturated fats, right? So whole foods, in this American Journal of American College of Cardiology review, was actually offering a different perspective. Don't just think of saturated fats as all evil. Think about what type of foods provide that. And if you're going at the whole approach, you're in general more safe. And recognize saturated fats, there's so many different types of saturated fats. But if we're talking about unprocessed red meat, whole fat dairy, safer than the other image that I shared earlier with you. So something to consider. And then I shared with you all, again, this is just level setting, The relative risk piece, if it's 1.0, it's balanced. Anything above that, it's a higher risk, and anything lower is a lower risk. And that, quote, saturated fat may not be as, quote, bad as we've all thought. Now, this is contrarian. AHA and others will say 5 to 10% should, of your diet should be, quote, saturated fat. But I think you're going to hear differing views now coming out. And these are some large meta-analyses that look at and say, well, actually, it's about, balanced for all-cause mortality, cardiovascular disease. It might have some protective effect with diabetes and even stroke. We also talked about fats in the form of oils, seed oils versus fruit oils. Like the seed oils are these sunflower seeds, oils, safflower oils, and then the fruit-based oils. So this is all review, guys. But again, hopefully repetition is helpful. We're going to move into the new stuff soon. I shared with you this, I don't think I shared it with you, but I wanted to ask you this question because we just showed you the image of the polyunsaturated fats, right? That's those vegetable oils that everyone says, hey, you should just do that. Don't eat the lard, don't eat the saturated fat. Take all your vegetable oils. That's the good stuff. And so why doesn't polyunsaturated fat also lower LDL? And the answer is yes, it does. That's maybe why we say that, right? Often the traditional thing is get away from the saturated stuff, go to the polyunsaturated vegetable oils. Because it's like, hey, our thinking is, doesn't saturated fat increase LDL? And the answer is yes, saturated fat does increase LDL. Well, then if LDL is a bad thing or a culprit, doesn't elevated LDL increase cardiovascular disease? Like that's what we've been taught this whole time, right? Focus on the LDL and bring that thing as low as possible, and you'll drive cardiovascular disease down. Well, that depends. So let me just kind of review that arc in case it wasn't clear. We've been fat phobic for the last 40 years. We've said, because we have said that saturated fat increases LDL, which it does. And then we made the jump that LDL, all LDLs are bad and cause cardiovascular disease. So then we said, okay, well, let's substitute out that saturated fat, put in the vegetable oils, the quote PUFAs, polyunsaturated fat. And vegetable oils, those seed oils, are great because they lower LDL. They do. So then how do we hold this, Dr. Chen, what are you saying? It sounds confusing, right? Let me try to walk it through then and answer it with not only this study, right? Because I shared this with you study, but I'm going to share the mechanism after this. Just as a reminder, we saw this study. It's an important study. It came out as a re-review of prior data, which showed that PUFAs, omega-6 cooking oils from safflower oil, were not always that great, right? They may reduce your LDL, but there was an increase in all-cause death by 62% in patients who already had heart attacks. These are patients who already had heart attacks, 348 of them. And then they separated them out, randomized trial, said, well, what happens if I switch out their saturated fats and put them on safflower oil versus just keep them on their regular saturated fats? And so there was something concerning about this. But then the question is, why? What's the mechanism behind here? So let me pause to see if there are any questions so far. I don't know if you guys saw how I was trying to connect the dots between saturated fat, omega PUFAs as another form of fat, cardiovascular disease. Questions? I'm going to try it on then and say, well, let's get to the why. How does this all connect? And this is what we do in primary care a lot. We look at LDL, right? We say, well, isn't that what matters? That's the biggest and most important thing. Well, I want to put forth that LDL type, the type of LDL and the size of these LDLs and the number, if you will, actually matters for cardiovascular risk. So that you can have larger LDL. It's not atherogenic. It doesn't cause those atheromas. It's not going to lead to a lot of the blockages. You can also have these smaller, dense LDLs that we know are atherogenic. These are the small ones that get into the endothelium of your cardiovascular system and cause plaque formation. When you order a lab test, a lipid panel, You have no idea what type of LDL it is by looking at just the LDL number itself. That's why it's important to think beyond just the numbers of LDL, and then to understand what is the environment in my patient, in their body's physiology when I check their LDL. Are they a metabolically healthy person who may have a higher LDL, but it's more of this fluffy, big stuff LDL? Or are they metabolically unhealthy with tons of small, dense, atherogenic LDL? You can't tell on just looking purely at LDL. You have to look at other indicators. And some of them are more fancy. We don't normally order them in primary care. We can get LDL counts, particle size, and all of that stuff. When it comes to what we've been teaching and sharing, these are the two pictures, or the 2 points I want to make. The high sugar and high insulin states, that'll lead to a modification of your LDL. It'll glycate it, just like your red blood cells are glycated by lots of sugar, and that's how we measure an A1C. Well, your LDL also gets glycated. High sugar environments bind to protein. So this begins this process leading to a more fully oxidized state, which is more atherogenic. So that's more of an insulin resistance piece. We've talked about that donut every day, that cereal every day, creating a high sugar milieu and then insulin following it. Well, what about the seed oils, the vegetable oils, the PUFA, omega-6s, all three names for the same thing? Well, that's here. And you can click on this picture if you want, just to get an understanding of the proposed mechanism. The PUFA omega-6 is that when you eat more stuff that has the PUFA omega-6s, it actually gets loaded into your LDLs. And those LDLs are much more susceptible to oxidation and to reprocessing. So this is the thinking. This is the rationale for why we are seeing some of this disparate information coming out. Pause and digest. What are your questions around what I just shared? Was it unclear? Was it as clear as mud? I don't expect everyone in this room to track everything I'm saying, because some of this is kind of more medical, right? Come back to it if you have questions on this, okay? But this is just the whole piece on fats, if you will, or just a way for us to understand why the whole food fats make more sense than highly processed fats. Okay, so let's get into like primary care. So you're looking at your labs, and you get this typical, this is Miss C. Daphne, you want to talk about Mrs. C again and go through the range and how we interpret this lab set?
Sure. So Mrs. C, we got her values, and her triglycerides were 200, her HDL was 32, her hemoglobin A1C was 6, and her ALT was 35. And we talked at the first session, and everybody agreed that her HDL was a little bit low for sure. Her hemoglobin A1C put her in the pre-diabetes zone, and her triglycerides were high, and her ALT was a tiny bit high as well. And given the setting of her sort of abdominal discomfort, and her other labs might suggest the beginning of non-alcoholic fatty liver disease, which we're figuring out can actually be pretty symptomatic in a lot of patients, giving them kind of a chronic low-grade abdominal discomfort. And, when we talked about this, you all agreed that these were all the hallmarks of insulin resistance.
So do you see LDL here? You don't, right? So you will see an LDL, I don't put it here, but you will see an LDL. The point here is to share that in trying to understand what is the environment, the milieu of that LDL for this patient, you have clues here. The fact that your triglyceride to HDL ratio is greater than 2 or 3, and there's some references here, suggests a higher insulin state and certainly higher cardiovascular risk. So it's almost, this is about 6 to 7 time ratio, right? So this is telling me, when I look now at that person's LDL, I'm a little worried. That LDL is probably a little more oxidized. And this person definitely has a higher cardiovascular risk. And certainly the fact that they have the glycated products, A1C, that's going to contribute as well. I hope this is going to help you all, at least when because in primary care, we struggle sometimes just looking at these lipids. We just kind of shoot reflexively. If there's an LDL over whatever, we just put everyone on a statin. But there's some, hopefully, nice nuance that you're picking up as we go through this. Okay. It's quiet on the chat front. Does anyone want to venture a question out loud? Okay, so you all have seen our little 5-pattern piece for metabolic syndrome and insulin resistance. When I, looked at lipids before, I was like, what's this thing about, why is there such a focus on triglycerides and HDL? What's the mechanism? How does it work? And I need to understand things before I can make sense of them and then kind of pass it on to patient care. So we know that insulin resistance increases all of these elements, right? So you can start looking more, and then for HDL, it decreases it. Well, what's this interrelationship on this? The mechanism is basically triglycerides. When you have a lot of them, all this fat in your body floating around in the blood cells or in your blood because of too much sugar in your body, that deposits, these triglycerides deposit a lot of pieces of substances, if you will, onto the HDL. And then the HDL becomes targeted and it causes increased clearance. So the HDL goes away. And so your HDL drops. So anytime your triglycerides go up, your HDL drops. They're just related that way. So this is just something to bring it back home to what we do often in primary care. We're often calculating ASCVD, calculator risk, right? This is our atherosclerotic cardiovascular disease. This is your heart attacks, your strokes, your peripheral vascular disease, the claudication when people, blood vessels in their legs are all clogged up. So we use that calculator, and just to level set, can you all tell me how and when do you use that calculator? For those who use this, I don't expect behaviorists to use this or care coordinators necessarily, but for the clinicians in the room. Risk of CVD, yeah. Your system sets 40 as the start. Oh, for age, yes, 40 years old, yes. There's a kind of a lower limit and then an upper limit. When do you actually apply it? Do you apply it to someone who already has has a stroke? You actually need to calculate it, or who already has a heart attack? You don't need to, right? So if they already have it, this is really for prevention and to kind of risk stratify it. But they've already had it, they are needing a lot of treatment, and you can add the food as medicine, and usually we start the folks on the statins for these, right? If they're already on the statin, right, and you're doing lipids, you don't need you wouldn't calculate your risk score because they're already on the statin. But when I'm in clinic and I've been working intensively with patients who are doing this work together, they may say, you know what, I want to try myself off a statin. Now, if they have diabetes or they have heart disease and stroke, it's a longer conversation, but they're just kind of doing prevention. I might say, okay, let's see what happened. What did your numbers look like now that you've made all these changes? You've cut out the sugary drinks, you've cut out the processed carbs. Let's look at your cholesterol numbers off statins. Now we have a sense. And if they're still high, then we say, hey, we got to have a conversation. We want to get back on statins. You want to use this as an opportunity to motivate and move on your other markers by intensifying the lifestyle, the life habit stuff. Remember, this is a 10-year risk prediction for heart attack or stroke. Also remember that it's this shared decision-making, what I was just trying to demonstrate. I think in primary care, we're so quick to just do a calculation, see the math, and then prescribe a statin or prescribe just because that's what it says we're supposed to do. it's important to understand some of the thinking behind this. And they got a 10-year risk prediction. You got some time to work with your patients if they're willing. And then side effects are not a joke with statins, right? You can see cognitive decline, you can see diabetes increase. They're certainly very powerful. And you can certainly see all the muscle aches and all of that. So you want to be judicious. We're going to close out this thing on fats by just thinking about dairy and dairy fats. This is just some, again, different thinking out there, right? We often think of using dairy, especially milk, because we need enough calcium to prevent fractures in our bodies. The recent systematic reviews show that milk itself does not prevent fractures. And because of its IGF-1 kind of mimicking characteristics, it can increase cancer risk in men who already have early signs of, prostate changes in their cells or endometrial cancers. Bottom line is, if it's in your diet, go for it. Have a serving a day, and that you don't necessarily have to go to the non-fats. That whole fat is okay at these amounts, provides the benefits of satiety and potentially lower cardiovascular risk. This is, I would recommend you to read Willett and Ludwig's work on this space. They're really thoughtful and bring some new thinking on this. Questions on this? Okay, we're going to move on. How much calcium do we need? Just because we're talking about milk and we associate the two, conventional thinking is, and this is all about micronutrients right now. We've moved away from fats. We're now we kind of moved into saturated fats, and now we're kind of tying into calcium just because it's often related. People think about it that way. Do you all remember like the conventional guidelines around how much calcium we need, depending on age? I remember when I was, earlier in my days, I'd be like calculating it with all my patients and like, Mom, you have to get this much, you have to get this much calcium in your diet, or you're gonna get osteoporosis, right? And we have all these numbers. Another way to think about it, again, just evolving work in this space, is to simplify it and just say, give an updated perspective. The WHO perspective says 500 milligrams a day. Systematic reviews, as I shared earlier, no relationship between hip fractures and if you get between 500 and 1,000 a day. And then the UK, just for international perspective, they're 700 to 800. So something between 500 and 1,000. And so then the question is, great, so do I need to count every milligram that I'm doing to figure out if I'm getting this? It's not that hard actually in clinic. I can give you a rough and ready one. This is just something I've used over the years. I call it the rule of 300. It's not exactly 300 because it varies, but it's a simple way when I'm in primary care, just trying to say, you don't have to get the 1,500 necessarily. You can get, and where do you get this food? You can get it from soy, cow's milk, a cup of that, it's about 300 milligrams. Yogurt, hard cheese. Tofu has a good source of calcium. The green veggies we've talked about, 2 to 3/5, depending on which type of greens. And then if you're having folks that just want to know, well, what about nuts and other pieces? So if you're going to 500, 1,000, 2 cups of something here, or a cup of, half a cup of soy. I put the soy here as well as here. You can get a lot of it through your veggies. Any questions, any surprises on this? I'm going to turn it to Dr. Miller, who's going to share with you really interesting thinking just about a different way to frame micronutrients and a different way of just getting nutrient density stuff into your diet. So here we go.
Yeah, so the reality with most of our patients is that we just have minutes to do this stuff. And we're also giving you a lot of information here that I know is new and can sometimes feel like it's just too much to retain in terms of equivalent doses of tofu versus calcium. And especially for those of you who are taking care of children, really wanting to figure out if they are getting a diet that has enough nutrition in it. So not just focusing on calories, but really nutrient density. And it turns out that the diversity of the diet is probably the best marker for whether you are getting those micronutrients. And even a good balance of macronutrients, so the proteins, fats, carbohydrates. And this is something that's been very well studied overseas in countries where there really are nutrient deficiencies that are much more common. In the US, the reality is that most folks are getting enough micronutrients. They're just actually getting way too much sugar and too many calories. So we kind of have different nutrition problems here. But Gemma just wrote, eat the rainbow, and that is so true. But I am going to have you expand your idea of rainbow a little bit. And when they do these dietary diversity scores to really assess what is an adequately diverse diet, it's actually within 7 food groups that are pretty easy to memorize. And if you go to the next page, the 7 food groups being, actually, they have it here as 10, but in my brain, I often don't have the other vegetables, other fruits, or other vitamin A rich fruits. I don't, fruits or vegetables, I actually don't have those. I have the first 7, basically. So I will assess for grains, pulses, nuts, dairy, meat, poultry, and fish. And I actually often put eggs in with that. I should have changed this around a little bit. Dark leafy greens, and then finally fruits as the last one. And if you can have those different categories and ask your patients about them, and if they are hitting 5 out of 7 on a daily basis, that is probably a pretty good indicator that they are getting enough micronutrients. It still does not mean that from a diabetes or heart disease standpoint that their diet is totally healthful, because as I said, here in the US, we have an excess of calories, which is sort of part of the issue, and especially a excess of sugars. But at least from the micronutrient standpoint, that can give you a lot of reassurance. And so let's look at Mrs. C. Let's go to her dietary recall.
You want to say this one?
Yeah, so just for you to know, there's actually a study underway right now looking at, in the US, at trying to use dietary diversity as a great marker for nutrient density. And it hasn't been completely validated yet. It's been used mostly on the population level. So I just wanted to put that there, that this research is evolving, just to understand. But my guess is that what we're going to find is that it is a great indicator.
And I think, Daphne, I'd be curious, do you often use this when your patients ask you about, well, should I take a supplement or should I take a vitamin?
That's a great question. And yes, I do. And I often say, you know what, that supplement or vitamin is just going to be coming out of your wallet and your pee, but is not necessarily going to be doing much for you. So let's look at Mrs. C. Remember, we did that 24-hour dietary recall on her. If you can just give it all to us, Stephen, what you can see, and I did the different food groups by different colors. So the whole grains, remember, that's one of them, and she's having corn tortillas and whole wheat bread. The dairy being another one, so the creamer and the coffee and the scoop of ice cream. The fruits being her glass of orange juice, the vegetables being another one, and then the meats in the chicken stew being another one. And the papaya also being part of the fruit. That really, I put the papaya in a slightly different color because that is a vitamin A rich fruit, but it really is also a fruit. So does she meet the minimum of 5 different food groups in a day? Anybody want to answer that one?
Lila says no.
Okay, why doesn't she, Lila? Mila?
She doesn't have vegetable at lunch, so she might be eating less than 5 servings of fruits and vegetables a day.
Okay, so you're focused on servings. Yeah. So actually, when you do dietary diversity, we don't worry so much about servings. We really want to see, are they hitting these groups at all in the day? So from a dietary diversity score, she actually is. Because we're assessing micronutrients here more than, when Dr. Chen is talking about fruits and vegetables and trying to do all those servings, that's actually from the bigger picture of a management of blood sugar and so on. We're actually looking at dietary diversity to assess micronutrient levels. And she actually does meet those 5 different groups a day if you look at this. And so the point being here that it's actually really important to understand the difference between that. So a lot of our patients who might not be doing so well from a dietary standpoint are actually probably getting enough micronutrients, but there's other issues that need to be tackled with her, right? So her excess of corn tortillas, her 1 scoop of ice cream might be something we would look at, the extra rice, the Sprite, the potato chips, and so on. Yes, she is eating a lot of carbs and sugars. Does that make sense to folks, the distinction there?
I wondering also, as a follow-up to the question that Dr. Miller is asking, is when we say micronutrients, maybe I should have just said it earlier. Micronutrients are like the calcium, the calcium conversation I was sharing earlier.
The iron, the
iron,
zinc, the
magnesium.
vitamin D, all of those. Yeah, the things that you are likely to get in a multivitamin.
That if you, from a dietary diversity perspective, get a sense of their diet, you know that they have 5, you can kind of put that question to rest. Certainly, if you have a vitamin D that's low, then that's a different question. Can treat that therapeutically or more sun and all of that. But in general, when people are worried about, am I getting enough of the vitamins? You hit that 5 or the 5 out of the 7 in the way that Dr. Miller described, you can feel pretty comfortable that they're going to have their basic micronutrients met. And then the question is, like Ronald is saying, where's all the sugar? And that's what I tried to do in highlighting it in the purple. Like there's a bunch of added sugar there that is there.
So yeah, there's sometimes this expression stuffed and starved, which is kind of how we are in the US, and that we are getting almost this, excess of food, but in some ways we are, not eating right because of all that we're stuffed on. But the micronutrients are often there. The red flag for me is often in kids. They will literally be eating 2 food groups a day. Like everything they eat is soy and wheat, for example, or soy and dairy. Then I'm actually quite concerned. If meat is one of the food groups, sometimes I'm a little less concerned just because there's a heck of a lot of nutrition in meat, but it still is a red flag for me. So it's a way of really making sure that, your patients are at least meeting the minimum in terms of micronutrients. And it's also sometimes a way of giving someone positive feedback. So saying, hey, I know there's some things we need to work on with your diet, but here's something that I think you're doing really well. You have a lot of diversity there. Any questions, or if not, we will move on.
All right. So we have marched through, we've covered 1, 2, and 3. We're about to go into spices and salts, right? The excess salt and the spices for taste. So here we go. Got all these great spices on the side, and I just said remove excess salt. And I think this is a shift because we're not necessarily saying all salt is bad, but there's some interesting information coming out on salt. But let's look at this patient. Do you want to say more about the patient again, Dr. Miller?
In terms of her blood pressure, we see that it is slightly elevated, above both ACC and AHA standards, and that her waist circumference, we've already talked about that it's a little bit larger than what we would consider healthy and indicator of central obesity, which is the most concerning kind of obesity. It's sort of adiposity around the heart and organs and in the abdominal cavity. and BMI, which we already discussed, is maybe a little less of a useful indicator in terms of metabolic health.
And just that, in primary care, we often think, oh, 140 over 90, hit 140 over 90, then start treating, these normal ranges, 120, everyone's in the 130s. Well, that's that 130 range, that early, right below 140, right above 140, is an opportunity. That's where we have the opportunity in the exam room to think upstream and say, what's going on? Why would that patient's blood pressure be above 120? Is there an insulin piece? Is there an inflammatory piece? Is there a weight piece? Is there all of these other pieces that are coming together to conspire to bring that patient over time up in terms of their blood pressure? So just in terms of salt, because we've been taught in medical school about salt, and maybe in nurse practitioner school as well. Salt is another marker for highly processed food when we're talking about packaged foods. Average salt intake, and this is all from FDA, WHO, AHA, average salt intake in the US is 3,400 milligrams per day. That's a lot of salt. The WHO and AHA recommend 2,000 to 2,300. And then when we get into kind of eating regimens like the DASH diet, they have a low salt one, less than 1,500, and then kind of just the kind of the typical standard, let's get less than 2,300. You may all remember that 2,300 milligrams per day. Actually, I don't know, do you all remember how many teaspoons is that? So a quarter of a teaspoon, actually, or a 0.4, 2,300 milligrams is about 1 teaspoon of salt. The 1,500 is around 2/3 of the salt. So just as a kind of reminder, a marker, and you remember me saying this in terms of teaspoons of sugar versus grams of sugar, both are important to know, because when you're doing tactical work with your patients and trying to help them read the label, now you can give them numbers to remember, or a concept like, hey, when they think about how much total salt you need, about a teaspoon, which is 2,300 milligrams or less sometimes. Now, there's different studies. This number 4, the 4th point is very interesting in that, this is like one of the early studies that said, hey, there's some people that are salt sensitive. It can range in normotensive folks who are non-hyper, they don't have blood pressure issues. So normal blood pressure, 26%. With some patients who are hypertensive being very sensitive to salt, up to 58%. These numbers don't matter that much. There is just the concept is there is a portion of the population that is sensitive to salt. And if they're hypertensive, there might be a higher portion. There's actually potentially even some kind of race equity issues around that that you can read about. So then what's our take on this, right? Because salt makes things taste good. You need salt. If you don't have any salt, you're not going to do well. But let's walk through some of the evidence and the thinking. So one of the important eating patterns out there is the DASH diet. When I was studying and understanding the DASH diet, I got really fixated on servings and literally got, what's my patient? Do I need to get them to 6 servings or 6? I moved away from all of that to just say, it's a lot of veggies. There's some protein, limited fats and sweets. They still use the low-fat dairy because it's an old, this is kind of the traditional approach. And we've given you other views on dairy. But it's not a lot of dairy per se, although this to me seems like a lot. It's more than the ones that we had said earlier from Willett and Ludwig. Grains, that depends. Like for some diabetics, you may not even want to go down a lot of the grain pathway. But what I take away from the DASH diet, aside from lots of fruit and veggies, is the sense of lowering the amount of salt. And there's the 2 pathways, the standard sodium, 1 teaspoon, and then the low sodium, about 2/3 of a teaspoon. And when we talk about the connection to insulin resistance, because most people, especially when we went to med school, we thought just really about salt and its impact on the kidney. But there's an insulin resistance piece here. And so you're going to see this circle with the 5, the blood pressure. Well, what's the mechanism? The mechanism is that the insulin itself, right? We know that salt works at the kidney and retains fluid, but the insulin and high insulin states increase salt retention by activating aldosterone, which helps you keep fluids in your body, keep your salt and then the fluids that follow. So that's what increases fluid retention, which contributes to blood pressure. And that's why when the AHA and other big organizations say you got to cut the added sugar because it can actually help blood pressure, there's a reason. Because traditionally we think it's just about salt, but the sugar itself can also have an impact, and the salt can have an impact. So you got sugar and salt working and conspiring together. This is just some of that primary data when it came out in the New England Journal from the DASH diet. And it was basically showing if you had a lot of fruit and vegetables and you had they tended to go with the low fat diet, low saturated fat back then approach, you could see significant changes in blood pressure and both the systolic and diastolic within 2 weeks. I mean, this is significant, an 11-point drop in blood pressure and your systolic blood pressure just by being on a food as medicine regimen, stronger than a lot of the medications we offer our patients, 5.5 for the diastolic. So when it comes to, and I shared this, just the DASH diet, then, what's the equivalent? If we're going to go the low salt DASH diet for some of those patients and you're trying to solve, what's their food equivalence? We know that 2/3 of a teaspoon is 2,300. Well, what's 1,500 milligrams look like? If you have a lot of patients that maybe a lot of Asian patients or folks that just love the fish sauce from Vietnamese food or soy sauce, 1 tablespoon, which is 3 teaspoons, that's about it. You got 1 tablespoon in your food, you're done for your 1,500 milligrams if you're going to push in that direction. 1.6 for the just regular soy sauce, and then 2.5, you have more room to go because it's low salt there. Some of the fish, dried fish, chips, interestingly, for this type of chip, you get a lot of chips. That's a lot of chips. They hit your 1,500. And the Big Mac, a whole Big Mac and a half, that's your salt intake for the day. If you're salt sensitive and you're thinking, maybe I don't need so much salt. Do you all have other foods that you recognize that have a lot of salt from your traditions, from your respective cultural traditions? Processed meats, tons of salt, right? Thank you, Carlo. Krauts. Oh, like sauerkrauts, Megan? Yeah.
Yeah, yeah, sauerkrauts and kimchis and stuff like that.
Right. Cured foods, that's right. Shrimp paste is kind of like the fish sauce. Yeah. I mean, and salt is powerful because it's a way of preserving food, right? So, I want to give this over to Dr. Miller, and of course, yeah, the bouillon cubes, when you're making your base, your stocks and stuff like that. Daphne, you want to talk about the sodium wars? Instant noodles for sure, Bay.
Yeah, so just to understand that this science is not so clear cut, and this has been an eternal debate. Most of this research has shown, and even in RCTs, but mostly in cohort studies, that when you actually look at sort of overall mortality based on very low sodium diets, that folks who are on these diets actually tend to have higher mortality rates, even when controlling for disease. So really, I think what the take-home message is that there is a small percentage of patients, maybe under 10%, who are extremely salt sensitive. They generally know who they are because they see, their legs just swell excessively with a little bit of salt diet, their blood pressures go up and so on. And there are folks who really do well to sort of excessively control their sodium. But for most folks, it probably ends up translating into poor quality diet overall, because sodium is this great spice to make your vegetables taste good and to make other healthful food taste good. And there might actually even be some repercussions at the level of the kidney. When you are restricting sodium, it changes the gradient there and might actually cause a paradoxical increase in blood pressure. So I really, in terms of the priorities that we have as clinicians, it's to target the folks who are in the revolving door of CHF and going into the hospital every week, or folks who really have blood pressure that seems to be sodium responsive. But otherwise, to more focus on foods that are super high in sodium, like Dr. Chin mentioned, the processed meats and so on, and not have patients spend too much time counting salt. And really just to focus on not cooking with it and using it at the end of the meal at the table to spice the food, because that's probably the best way to use salt. And that's the image that I have here. So I teach a healthy cooking group once a week, and we don't use salt in the cooking at all, but we allow people to sort of use as much as they want as they're tasting the food. And people are really surprised how little they actually need when they sprinkle it on the top of the food. I think a lot of the salt flavor gets lost when you cook with it, and so you end up with excessive salt inside the food that you're not even benefiting for in terms of its culinary effect. But I usually find that somewhere around 20 to 30 grains of salt will change a plate of vegetables for me, like a really small amount.
I think that what you're hearing here from Dr. Miller and I, there's some nuance to the salt, but there's also not nuance to the salt too, and that our food environment, the processed food environment, does have a lot of salt in it. And so if you're at like 3,400, 3,500, 4,000 milligrams of salt, your body may be able to handle it, but there's something going on there, and that's the public health side of the house. So I don't think it's necessarily wrong to reduce excess salt. And it's not, you don't have to go all the way to totally take it all out because of the effect on taste and some of this other information. So part of our work here together is to equip you and to share with you what are some of the controversies, what are some of the wars, if you will, on nutrients that are out there. So you can try it on with your patients, because this stuff's going to change in the next few years each time. And you may have patients, I have patients tell me, I get really swollen when I eat salt. I'm like, okay, maybe you're salt sensitive. So let's try the alternatives. Let's add the spices. And with that, I'm going to turn it over back to Dr. Miller to do the section on spices.
Yeah, so I love working with spices, not only because they are their own pharmacopoeia, or sort of set of medicines for us to use, but they are these kind of delightful flavors that patients are really happy to take, much more so than medications. And because spices do make vegetables really tasty, which is sort of my goal, is to sort of use these different things to make vegetables tasty. So when I work with patients around spices, the first thing I have them do is the same thing I have them do when I'm working with them around veggies, is I have them make a list of spices they're using already and that they love. And it's amazing how many of them generate a pretty robust list. What are some spices that you guys love? Just throw them in the chat. Paprika, says Ronalyn. Paprika, says Gemma. Okay, paprika is a popular one, which is a terrific spice. Other ones? Cinnamon, yes, and that's a fantastic one, because not only the curry, which we know is a mixture of lots of different spices, but wonderful. Ginger, garlic powder, oh my gosh, Cajun spices, which is another wonderful blend. Garlic and garlic powder, turmeric, fantastic. These are great. You guys are hitting the highlights for sure. So if you could go to the next slide, Stephen. If you guys want to grab this QR code with your phone, this is a nice review article that actually talks about sort of medicinal doses of spices that can be used for various, for these, these top 10 spices are sort of on my list on the left. Someone just wrote onion as a spice. I actually think of onion as more of in the vegetable, but it's a root vegetable, but it's totally can be thought of as a spice too. Basil is a lovely spice that someone just wrote about. So yeah, grab that article and take a look at it. And these are sort of the top medicinal effects of spices. If you can give us that, Stephen. There we go. To control blood glucose and appetite, and as a digestive aid. They're anti-inflammatory. They've been used for centuries as natural food preservatives, so bactericidal, to kill the unwanted bacteria in your food. You know that because you can like leave your hot salsa on the table in 90-degree weather and it doesn't go bad. For blood pressure control and lipid lowering, and they're neuroprotective. They have anticoagulant effects, and they can help with nausea, especially in our pregnant people. So next, I thought I would just give you 4 examples of medicinal ways that I use spices, and then you guys can actually use that article and develop your own little RX sheets for spices. But in turmeric, it is thought that one of the more active ingredients in turmeric, and by the way, we never can, there's so many chemical compounds in each one of these spices that it's misleading to say that it's just one of the chemical compounds that has the medicinal effect. That's the thing about whole food medicine, is we just don't even know which part of it's working. But curcumin really does seem to have a very strong anti-inflammatory impact. And 200 milligrams of curcumin exists in about 1 teaspoon. And in terms of equivalence, it's probably about equivalent to about 250 milligrams of ibuprofen in terms of its anti-inflammatory effect, is what the studies show. What's really interesting is if you mix the curcumin with a little bit of black pepper, for whatever reason, that does increase its absorption through the intestinal mucosa. So in terms of pharmaceutical impact, I usually have patients do 1 to 2 teaspoons a day for joint pain, for patients who have, osteoarthritis or some polyarticular inflammatory arthritis, or, dealing with a hip issue. And sometimes I'll use it with ibuprofen, to decrease the dose of the ibuprofen. Some people prefer to buy it in capsule form, even though that's much more expensive, because they don't like how the turmeric makes their teeth look yellow after a while. And so that's their choice if they want to do it. I personally put 2 teaspoons in a smoothie every morning and have it that way. And that's sort of my joint medicine for the day. So next. Cinnamon. This is a really key spice for any of you who are working with patients with diabetes, because cinnamon it actually registers in the brain as sweetness, and yet it has no glucose or fructose to raise blood sugar, okay? Or, tiny, tiny minimal amounts. So that is probably one of the more powerful ways that it works as as a diabetes therapy. But on top of that, it does seem to have some hypoglycemic effects, probably by promoting glucose storage in the liver. And you get the cinnamon, 2 grams of cinnamon is equivalent to a teaspoon. And I tend to prescribe about 1 teaspoon per day. How much does that lower hemoglobin A1C? Well, that study that you have does discuss this. It's going to likely be less than a point. It's somewhere between 3/4 and 1 point on average. But for your patients with prediabetes, or people who are really looking to kind of diversify their therapy, this is definitely something to add to the mix. And maybe you will get them down on their other medications or prevent them from starting on medicine, and keep them on a more low added sugar diet, because the cinnamon, you put some cinnamon in your yogurt and all of a sudden you don't need sugar in there. Next, garlic. This is a very key one. So 1 clove of garlic is about 4 grams. And within that, it has about 3.5 to 4 milligrams of allicin, which is the active ingredient in garlic. The trick though, is in order to get allicin to be released, you actually have to take the compound allicin, which exists in garlic, and crush it. And then all of a sudden the active ingredient gets released. Studies show that if you have 1 crushed clove of garlic a day, that can lower your systolic blood pressure about 8 points. You can put that in your salad. Most of you are not going to want to put that in your smoothies, but put it in your salad. Eat it, with your veggies. Folks ask if it's cooked, will that change its pharmaceutical effect? Maybe a little bit, but it's still, as long as it's not overcooked and is sort of added at the end. But you get the greatest effect is when you eat it raw. The garlic salts generally are not the best way to go because you're getting salt as well, but just the freeze-dried garlic can be fine. For Mrs. C, this might be all the therapy she needs, right? Because she has borderline hypertension. We might be able to push her over the edge with some exercise, some relaxation, some dietary change, and a clove of garlic a day. Who knows? Next. And finally, ginger, my favorite, 5 grams per teaspoon, okay, of raw grated ginger. And I prescribe about a teaspoon a day in 3 divided doses for patients with nausea. And that can be folks who are dealing with chemotherapy, but I use it the most in women who are pregnant. And it's been shown that dose, a total of 1 teaspoon a day, has been shown to be incredibly safe. Lucky accident that most women who are nauseated by everything still love the taste of ginger. So there must be something evolutionary there. And Gemma says, can it be frozen? And the answer is yes, it can for sure. And as you know, the best way to keep ginger in your home is to freeze it and then grate it from there, and you'll get just as much pharmaceutical effect if you do that. So those are 4 spices to start off with. And I hope you enjoy exploring spices because your patients will love you for it. If you start writing spices on your RX in your Epic or on a RX pad. Any questions?
We've been going long.
Move on.
We're gonna, so we just did completed 1 through 3. We're gonna take a 2-minute break and stretch break, and then we're gonna close out for sure, see how far we get with 5 and 6. So you're back in clinic this afternoon. You got 3 steps. And each step, so the first one's fairly quick and easy. Second step, you spend some time with your patients on replacing. The third one, really, some really nice opportunities there, especially throwing some of the spices like Dr. Miller was talking about. This 4th step is about shortening the eating window and frequency of eating. So here we go. When to eat, right? So we've mastered what to eat. Now we're going to when to eat. When to eat, I will say, is often not talked about. Nutritionists, docs, nurse practitioners, we focus on what to eat almost all the time. And it can be a tiring talk with patients, especially if you're taking more of the traditional, I'm just going to tell you what to eat. Instead of eliciting, well, where are they? And then doing this dance and having frameworks in mind to know what levers you're going to try on with your patients. So the when to eat is actually a nice, beautiful, I think, very contained way of beginning the one lever around time. And so I'll turn this back over to Daphne to go over Mrs. C and her meals and the timing of her meals.
So Mrs. C, remember we have her, what she reported as eating. Do you have her meal list? Oh, okay. Oh, this is how you did it. Okay. So we're gonna sort of ask it to her in a slightly different way, which is honestly the way I often ask it to patients at the beginning, is not just what they're eating, but I get the timestamp of when they tend to eat too. And this actually is pretty consistent for most folks. If you think of your own way you eat, it's like if you're used to having a pre-bedtime 10 p.m. snack, you probably do that most nights. I mean, I know for me, that's kind of how I am, a creature of habit. And there might be some days where you deviate, but mostly you're pretty predictable. So what we find out about Mrs. C is, we had some, concerns for her in terms of what she was eating, but when we look at when she's eating, what do you guys think about this? Any thoughts? 9 yeah, so on Mojado Road, yes, 9 p.m. dinner and 11 p.m. snack, or dessert and 11 p.m. snack. Yeah. What are you thinking that's late, huh?
Hmm.
Yeah, okay. And Gemma says, yeah, long eating window, says Megan. Yeah. So she's putting the first food in her mouth at 6 a.m. That's, hitting her stomach a couple minutes later. And then at 11 p.m., she's going for snacks. So yeah, she has probably at least, 17 plus. Thank you for doing the math for me, Stephen. At least 17 hours of eating. So I'm going to let Stephen talk to you about why that is concerning and how this might be yet another path to health for Mrs. C, not just in terms of what she's eating, but when she's eating.
Thanks, Stephanie. So this is her eating pattern, right? You get a sense from 6 a.m. to 10 or 11 p.m. She's grazing through the day. She has her main meals, breakfast, lunch, and dinner. She throws in some snacks and dessert somewhere along the way. Well, what's happening in her body physiologically, given the common pathway of insulin and insulin resistance? Every time she eats, in general, right, you all remember the curves. Carbohydrates are going to spike the insulin more. Protein has some, fat not so much, right? But in general, if she's going to be eating, she's going to be spiking her insulin. Insulin hangs out in the body once it goes down. It takes a while. And so if she's eating multiple times through this long window from 6 a.m. to 10 or 11 p.m., she's creating a high insulin state for her body. And what do our bodies do in reaction to high anything in our bodies? The body's smart, it self-regulates. It down regulates, so it becomes resistant. So I don't want to hear all that. I don't want all that insulin. I'm not going to respond to it anymore because it's just too much. So now I'm moving in towards that insulin resistance pathway. And when you have insulin in your body a lot, all the time, not just when you're eating, but just in general, because it's a half-life, it takes some time for it to drop. Remember what insulin does. It's not just opening your cells to glucose, which we're usually taught. It is also telling your body to store energy as fat. There is no way then to utilize your fat stores in your body, in your liver, or in the rest of your body, wherever it is on your body, your visceral or your abdominal central adiposity. You cannot utilize those stores when your insulin's around because it's physiologically telling your body store. I'm in a food-rich environment. I've got to store it because there'll be a rainy day when I don't have food, and then I'll start using my fat structure or my fat layers up. So you're just storing, and now it's storing so much, there's no place to go, so the sugar starts spilling out. And now we're beginning to see prediabetes and diabetes, right? So then the question is, well, snacking, right? I mean, she snacks, but a lot of us snack a lot. Shouldn't we graze through the day? Isn't that what the teaching was? I think the numbers are even higher now. This is back in 2011. Used to be the average snacking was about 4.95 a day. So every time you're snacking, especially if you eat that tasty donut, you're going to get an insulin spike. And that insulin spike's going to hang out. So you have multiple spikes in the day over a prolonged period. She's 17 hours. So that means the time in a 24-hour period that she has lower fasting is maybe when she's sleeping. That's only 7 hours. So she's storing over time, developing insulin resistance. So when to eat is a key piece in lowering insulin and insulin resistance. And the nomenclature in the science literature is time-restricted eating, TRE, or time-restricted feeding. In the lay press, or you'll hear it often talked about in different ways. You'll hear about time-restricted feeding, and sometimes the medical press, it's fasting mimicking diets, Walter Longo's work. Intermittent fasting is very popular. Some use therapeutic fasting. They're all variations of reducing your eating window to lower your insulin amount in the total day to give your body more chance to fast and have a lower insulin state. So Dr. Jimenez is saying, so maybe aiming for breakfast like a king, lunch like a prince, and dinner as a pauper is still applicable. Well, let's talk about that, right? That may be a pathway for her, right? How much you differentially load up at each meal or not. So let's look into this, but let's hold that thought. So what is time restricted eating, right? It's basically saying, you know what? One way of doing it is I scrunch down my eating window. So now I'm going to have an 8-hour window. This is one example. Well, the opposite of the 8-hour window of eating is when you're fasting, and that's 16 hours. So you often hear people say 16-8. I like to use the word eating window because it's easy for when I'm in clinic to talk about. But in this case, this person's skipping their breakfast. So they're burning fat roughly, right? They're utilizing like the glycogen from the overnight. First use up that from your liver overnight and then into your fat. They eat a lunch, depending on how they eat a bunch of candy at lunch, and that's going to spike them very high. If it's a bunch of avocado, not as high. And then a dinner, and they're done. They have their 2 moments when they eat, and everything else is a lower insulin state. Fasted state lowers insulin and insulin resistance, and now you're using up your fat stores. So that's the fasted state. You're trying to go the opposite of insulin resistance to insulin sensitivity. Your body's more sensitive now because it's not getting food continuously through the day. So let's talk about just beyond Mrs. C, who to apply this to. In general, we're not applying time-restricted eating to pregnancy. That's more of a different state. When your body's pregnant, it's feeding the developing child. And then children and adolescents, because they're growing so fast, we don't really worry as much about time-restricted eating in terms of trying to optimize that. I will say something about that, though. There is a way of thinking about time-restricted eating that is applicable. I often, for my diabetics, I don't want them to just do it by themselves. I want it to be under the guidance of a medical provider, because if they're on meds, especially, I've seen it where they start bottoming out their sugars because they're like, well, I need to eat sugar. Otherwise, these strong meds are lowering me out. And now I'm eating regular foods and not as high sugar foods. Now I'm dropping low. My insulin is not I don't need as much insulin, or my glipizide can be reduced. And then certainly you got to be careful. And I've seen a lot of patients who have some type of underlying eating disorder. The focus on control and eating in folks with eating disorders, sometimes the time-restricted eating can amplify that. So you want to be cautious. It doesn't mean you can't use elements of time-restricted eating, but to kind of go down to 1 meal a day for some folks, that could be really worsening, if you will, their eating disorder and kind of body image issues. So just be mindful of those pieces. Daphne, do you want to say a little about this SCANME literature and just how it's helpful?
Yeah, just that there is a lot of really interesting data emerging specifically around using intermittent fasting for our patients with diabetes. And this is one of the more recent reviews that really is clinically relevant for us, as it's written specifically for primary care physicians. And actually Stephen's going to get to some of the actually recommendations that came out of this. But I thought for those of you who wanted to look specifically at some of the studies underpinning this and more of the data, that this would be a good opportunity for you to do that.
Thanks, Daphne. Carly, you have a great question. We have a lot of patients who are working night shifts, graveyard shifts. And so, or they're chefs and they just eat, in between. I think the time-restricted eating approach actually lends itself well. It just means you eat, you just got to figure out where your eating window is. If it's during the day or the night, figure that out, and then figure out how many times you're going to eat within that, how many times you want to spike your sugar. So it's really 2 elements. That's one of the objectives, as the 2 elements within time-restricted eating. In terms of the effects, just to simplify it, we do see weight loss. We see certainly the lowering the insulin and insulin resistance. There's this kind of regulation of leptin. Leptin is one of these hunger hormones and satiety hormones, which is really more of an appetite suppressant. There's an increase in adiponectin, which basically increases insulin sensitivity. So you can get all of this in that scanned article, the QR article. I added this piece on circadian-based intermittent fasting. There's some really interesting research coming out to say, well, it's not just about your eating window. And this is to Carlo's point. Some people say just pick any eating window. And in general, I do that. I go with what's comfortable with the family or with the person, because they're maybe in a family and they have to eat dinner together. So they don't necessarily have to eat breakfast together. We do it with whatever works. I do think it's interesting, though, that there's some folks that have been studying what happens if you link your eating window to the sunlight. So you have your breakfast and you kind of have your, and you finish your day early. You don't have a late dinner, or you don't have even an early dinner. And there may be more effect from that that's happening for a lot of different reasons around the power of sleep, which we're not going to go into as much, but boy, is there some powerful work on sleep and insulin resistance as well. What might be some other co-benefits for Mrs. C if she goes the intermittent fasting or the time-restricted eating approach? Given her story, you remember the story that Daphne went through with her? Like, what were her reasons she was coming in for? Daphne, you want to chime in since it's your patient and you were able to see, possible less pain in joints due to weight loss? I don't know if you saw that in your patient, Daphne, since it's your patient, but.
Yeah, so absolutely. The feeling bloated. Yes. So that is often how I end up selling this to folks, is, for, because it feels to a lot of people like this is going to be a big deal to do this. And I say, well, not only is it going to help control your diabetes or your hypertension or your heart disease, but whatever brought you in the door, which is usually not those things, it is more of a symptom management, it might help that too. So absolutely, the feeling bloated so that you're not going to bed on a full stomach. And there is, there is definitely a connection between intermittent fasting or the calorie restriction or focused eating and inflammatory symptoms as well, so that her knees might feel better. But often this is how you're going to get patients to make this change, is through their other symptoms.
So let's look at Mrs. C's daily pattern. We see that. And so then the question is, how would you recommend that she even begin to do this? What is the language that you would use? How would you open the conversation with her? Thoughts, questions, or reactions? What do you guys do now, or for those who've tried this on? Sleep schedule, can you say more? Feel free, Mark Carlo, if you want to. We're going to bed earlier. Okay, yeah, so interesting. So like if she goes to bed earlier, she can't have that snack late at night, right? If she's not having that 10 o'clock, 11 o'clock snack, her eating window drops from 17 hours down to maybe, 12 hours, right? Depending on the time. So that's a nice tactical, simple way. Hey, what about going to sleep earlier and cutting out that snack, right? Great. So I'm just going to share with you how I'm thinking about it, right? When I try this on with patients, I do two things. I work with patients to identify what is their eating window. And to me, the opposite is their fasting time, right? But I explain it in terms of eating window. And then I go to what's the frequency of eating and drinking during the eating window. Basically, how many times are you spiking your insulin in your eating window? So I'll basically say at what, and this is stuff you can take on right at 1 o'clock when you start seeing patients. At what time is your first meal or beverage, not including water? And you might say not including water or coffee or tea without all the sugar and stuff. Like, what's your first meal or beverage of the day? Literally, sometimes if I have if my patient, I get a sense that my patient doesn't want to talk about what to eat, but is interested in the time base, and because I only have 15 minutes, I don't necessarily do a full 24-hour recall, because that can take time too. I might just go down the pathway. Just tell me what's your first meal or beverage. And then what's your last meal or beverage? And then I say, oh, interesting, 6 in the morning till 11 p.m. Let's count the hours in between. That's 17 hours. That's 17 hours when your body is kind of having a lot of spikes of insulin from the food you're eating. And we have a short talk about that. So that's kind of part one. And then I'll say, well, what about the frequency? So how many times are you eating or drinking or eating a meal or snack during that 17 hours? And I go, 3 meals, a few snacks, about 5 times. It's like that quick. And then I basically say, oh, okay, 5 times. So that's the number of times your insulin spikes in your body. So when your insulin spikes, your body goes into fat storage. And you've been telling me you want to lose weight or you want to do whatever, here's some thinking on that. And then I say, hey, so what's your thinking? Do you want to, based on what we said, do you want to shift the eating window time, or do you want to shift the frequency of eating? And again, this is more on the when to eat. Certainly, we're going to be, when you start using this in clinic, you start blending the what and the when, right? Oh, you have a donut at night. Well, maybe we want to cut that donut and switch it out to something else if you're not ready to just cut that nighttime snack, right? So there's lots of ways to play with it. Have your 3 pathways, when, what, how, and then have your 6 steps and dance with your patients and figure out where are they going to go, where can you move with them. Questions so far on how to introduce and the 2 major concepts? Okay, so in terms of progression, right, there's different ways to do it. Here's just one pathway. You could do it at a month interval. You could say, you know what, let's just do 12 hours. And this 12-hour eating window is safe for kids. It's safe for pregnant patients. It's safe for eating disorder, folks with eating disorders, because it provides some structure, but not too constraining. And in fact, if we go back to the 1940s and 50s, and 60s, that's what most people did. They ate breakfast, lunch, and dinner. And maybe 3 times, and not many snacks, and they were done. And then the rest of the time, their body was in fasting mode, because you're either fasting or you're fed. You have 2 states: you're fed or you're fasting. And that's what we did. But then we became a snack culture, a grazing culture. I'll tell you, my 7-year-old twins, when they're in school, especially during the pandemic, they had their 3 meals, and then they had all these snack breaks during school. So at an early age, they're being programmed, if you will, to eat small snacks in between. When I grew up, I didn't have snack time in my school. Like, I didn't have all these school snacks structured into my learning. So this is a nice and simple way. And you may say, let's just do this for 4 weeks, and then, or for 2 weeks, however you want to do it, and then, if you're able to do that, why don't you shrink it to 10 hours? If you want to go there in 10 hours, you're not going to get huge shifts, but you might get something. Let's go to, maybe at 2 months, you want to go to 8 hours. I usually stop at 8 hours for just a general patient, but if I have very motivated patients who are working on a bunch of metabolic health issues, I might guide them to the 6 or maybe the 4 hour, and even move them occasionally to OMAD. OMAD is 1 meal a day. I might do that once to twice a week. So this does a caloric reduction. I'm not as huge, and I'm not as I don't worry as much about calories as much, and I'm worrying more about the metabolics. But there is a caloric restriction piece that happens with time restricted eating, and then and I certainly see a lot of shifts in people when they go on some pathway here. Especially my diabetics, I'll tell them, track your daily fasting blood sugars and your 2-hour postprandial, and let's talk about that, and then we can titrate meds. Questions on this pathway? Have any of you been doing this or trying this on with your patients? And if so, what's coming up? Barriers, or what successes do you have? Great comment. We'll be talking about that. So Dr. Jimenez is asking, any comment on the idea of eating only till you are about 80% full? There's a Japanese saying that's around, kind of, and I can't say because I don't speak Japanese, around eating, so you're not fully full. We're going to talk about that in momentarily, so I'm going to hold that thought. Daphne, were you about to say something?
No, but I think that this is just a great example of the layering too, that you can sort of do these 2 concepts at once. Yeah.
Right. Great. So one of the things that comes up when Mrs. C starts this, or others, they say, well, aren't I going to be hungry? And I see this a lot with patients who are on high sugary diets, eating patterns. They're often very hungry once they start taking the sugar away, because the sugar drives the ghrelin, and we'll show you some slides on that, the hunger hormones. And you start taking away the sugar, they're like, well, I'm hungry. So you gotta be able to deal with this up front. Drink more water. Ronaldin, you got it. So that's one go-to. It's like, hey, drink water. Others. Water fills the mechanistically, it fills your stomach, stretch muscles on your stomach, which releases hormones for satiety. Doesn't last forever, but it's there. Yeah, more veggies and fibrous food. There you go, right? So if you're gonna try this on Mrs. C, when you eat, if you're going to eat 3 times or 4 times, let's go into the what to eat. Let's get some of the foods that are more fibrous, as well as the whole foods that have a lot of protein. Protein is shown to increase, be the best in terms of its effect on satiety. Have healthy snacks in between. So this and Armojados, small frequent meals, and Ronaldin's, this is where I do a little cautioning. And this is dancing with your patients. I tend to, when I'm trying to work with patients with when to eat, I'm working on their eating window. And then once we're clear about trying on an eating window, I'm working on how often they're eating within that. The studies show that if I eat the same calories and foods 3 times a day versus the same calorie and foods 8 times a day, even though it's the same calories and foods, the 8 times a day is worse on the body metabolically. The grazing is not as helpful, because the insulin usually spikes each time, and insulin hangs out in the body, giving your body a sense that it's a higher insulin state. So let's move on then. So, she starts it, you try these things on, you can kind of set up and say, anticipate you might be hungry for the first few days. If you start feeling cold, having headaches, constipation, diarrhea, nausea, some GI stuff that's just out of your normal pattern, you're weak and fatigued, or you're having sleep issues, either you're super energized because you're not eating as much, we want to address that. I often address this in a global way by just saying, it usually means that if you're feeling cold and you're getting some of this fatigue and weakness, that the density of your foods or the diversity of your foods, through what Daphne was saying earlier, is not enough. So your 3 meals that you're having, maybe it's just tons of noodles, right? And you're not having a mixture of combining with some fish or some meat, either chicken-based meat or red meat or whatnot, or nuts. Right, I throw in nuts and avocados as really nice ways to kind of increase that nutrient density to address what's happening here. When the body is feeling the coldness, the fatigue, that is often because the body is downregulating its metabolism. It's slowing down. And so because there's not enough nutrients or calories in the food coming in, so your body readjusts. The fatigue and sometimes the headaches, fluids with salt. This is where salt actually is okay. I liberalize the salt here if they're going here, and I just say, hey, you gotta get your electrolytes. So your soups are going to be great. Throw in some of the extra salt as needed, depending if you're salt sensitive or not. Daphne, did you want to say anything else here? Okay, I'm going to keep on going then. This gets into the mechanism for those learners that want to understand mechanisms, and then just to understand, well, how does this work? This slide is just saying that protein-based foods, fat in the foods, again, foods have all these pieces, fiber, they increase satiety hormones. That's here. These are these satiety hormones that many of us learned in medical school. Some of them will sound familiar because like GLP-1 is often used in the diabetes medicines now, right? CKK, cholecystokinin, peptide YY. These are just things that if you start learning and trying to understand why, these are well-documented pathways. You eat these whole foods with a combination of protein, fat, and fiber, you will increase your satiety hormones, which basically overpowers and decreases your ghrelin. Ghrelin is like growling. Ghrelin is your hunger hormone. An empty stomach begins your ghrelin. Your added sugar from that donut begins your ghrelin. Poor sleep increases your ghrelin. And when you're hungry, when you have your hunger hormones going, you eat, and you tend to eat whatever's in front of you. And if your food environment tends to be a lot of chips and donuts and stuff, that's what you're going to eat. So your ghrelin overpowers that empty stomach, added sugar, poor sleep. Any questions on the mechanism? Okay. So this is the other piece that I share with patients. I say, you're going to have hunger waves. This is physiologic. They shall pass. It will pass. They study the ghrelin waves when people are having their breakfast, lunch, and dinner, or if they're not even eating breakfast, lunch, and dinner, they're tracking the ghrelin hormone, and it just tends to have these peaks kind of physiologically. If you distract yourself, exercise, I just talked to a patient last week, do whatever during this time, this ghrelin will rise and it'll go away. And you're like, oh, I'm not hungry anymore, right? So it's not a death sentence if you're hungry per se. We are dealing in our communities with food insecurity. So we are dealing, and the language of food insecurity has been wrapped in the language of hunger in the past, and it still is now. It is important, and yet in communities where there's food, we're a food insecure community, but we have all this processed food. We want to figure out how to know that these are just physiologic pieces. It doesn't necessarily mean you're gonna go get out of bad health state if you're hungry. It will pass. This goes into the question that Dr. Jimena asked earlier. So checking in with your body. Am I 80% full? How do I actually think about fullness, being satiated versus hunger? And I want to offer something that I often use in clinic. I actually don't say, are you full? Because I'm going to ask you, you guys are eating food right now, right? Because I think lunch was provided. How do you know when you're full? I mean, the mechanisms around hunger, and it's all delayed. Your stomach takes a while to feel actually mechanically full. It takes a while for it to message up to your brain, your hypothalamus, where all this is happening. So how do you know when you're full? It's a delayed effect. It's not as accurate. So I don't usually ask the question, are you full? I ask the question, are you hungry? Are you hungry is a yes, no question in general. And I say, well, if are you hungry? If you're not hungry, great. Maybe you don't need to eat. If you are hungry, maybe it's time to eat, right? So it's a nice, simple way to kind of think about in the moment, especially if you're getting into this next step around mindfulness. Are you hungry or are you full? I'll also ask, why are you eating? And there's a nice little acronym, HALT. You're maybe eating because you're hungry, fine. You may be eating because you're angry or hangry. You may be eating because you're lonely for the L. You may be eating because you're tired. Remember, poor sleep can increase your ghrelin hormone. And then, how are you eating? And that's a little appetizer for a section that Daphne's going to talk about in terms of the mindfulness piece. So that's the piece. Address the hunger at the beginning. If you're going to do time restricted eating, you're in a fed or fasted state. You know that you can decrease by decreasing the processed foods. You can increase your whole foods, the veggies, the legumes, pulses, seafood, unprocessed meats, etc., and then utilize water. With that, we're going to shift into how to eat. But I want to pause and just check in with the team. We got 9 minutes, and I want to see, and Ronald is saying, make sure to take your time eating, chew your food. So maybe we're ready to move in, and I'll have Daphne speak to this. But any other final comments on when to eat and how to use that? Okay, Daphne, how to eat? You're on a mute.
So step 5, mindful eating. I often would talk about the 3 C's of mindful eating, which were cook, contemplate, and chew. And then I started to realize that a lot of my patients were not cooking, and that if I were to be honest myself, a lot of times I was not cooking. So I actually changed cook to compile. I replaced it. These 3 C's are really important pieces of talking to our patients, both about that physiologic response that Dr. Chen was referring to, of sort of when our ghrelin drops off, the hunger hormone, and also when leptin rises, which is kind of the satiety hormone, the same with adenopectin. They're also really important because what they do is they make us appreciate what we are eating and become slow us down, so that time gap between the stomach and the brain that Dr. Chen was referring to is more respected. So if you're chewing slowly and taking time to smell your food and really eating in a mindful way, your stomach has a chance to kind of catch up with your brain, if that makes sense, and for you to get a sense that you are full. So next slide. Oh, wait. Rest and digest. I like that. And chew your food slowly. My grandmother used to have this rule that you had to, chew each piece of food like 30 times, which I thought was pretty crazy. But I think it actually was a good health rule. I think the reason she used to have this rule with me is I would eat so fast that I would choke as a kid. I was in training to become a physician. When you're in residency, well, you have to learn how to inhale your food. But So I first wanted to talk about compiling versus cooking, because what I've learned both through watching my diet and watching my patients' diets is that a lot of us do a little bit more compiling than cooking. And that can be perfectly healthy as a way to eat, as long as it really is done in a sort of conscious way. So, I took this picture a couple weeks ago of what was on my plate. And, there was a couple tablespoons of feta crumbles, a whole can of tuna, an egg split open, some wasa, barley wafers, a handful of radishes, and then a bunch of carrots. And honestly, the carrots weren't even peeled because the skin of the carrot is the place that has the most nutrition. I quite like the taste of it, so just washed. And I, sat down for a meal and was dipping the carrots in the feta and, grabbing chunks of tuna and radishes and, using. So how many of you, just a show of hands, sometimes find yourself eating like this? Or, you can, Dr. Chen is, yeah. And it can actually be a pretty helpful way to cook or compile. The important thing is actually having this sensual experience of setting out your food. And I try and actually do it in a pretty way on the plate, even if I'm just compiling. And to be fair, I cooked the egg, so I was cooking. But that experience of setting out the food can actually be those first cues to your pancreas that a meal is about to happen. And already what is happening in your gut is that the first ghrelin is being released already and doing that sort of peak form. Gastrin is being released, telling your stomach to start producing digestive juices, and actually telling your large intestine to start moving in peristaltic waves so that you get a nice healthy digestion and your food moves through in a non-sluggish way. And so you're already priming your entire digestive system as you're preparing your food and looking at it and smelling it and so on. Next. Yeah, get that parasympathetic moving, exactly. So this study is just actually sort of a scientific illustration of what I was just describing. In this study, what they did was they took 2 groups of subjects. They were each about 30 people in a group. And they told one group in the anticipation phase exactly what they were going to eat at breakfast. And it was this nice, big, diverse meal. The other group, which is the dotted line group, they told them that they were actually going to be fasting until, lunch, basically. And what they did, though, was suddenly gave both groups breakfast at about 10 a.m., if you see that. But if you look what the ghrelin did, and this is a measurement of ghrelin in both the groups, it was really different in the fasting group as compared to the group the group that thought they were fasting as compared to the group that thought they were going to have breakfast. With the group that thought that they were going to have breakfast, their ghrelin dropped off very rapidly and they felt full. With the group who thought that they were going to be fasting, even though they ate the exact same amount and had the exact same breakfast, their ghrelin stayed high, much higher. And so what this shows us is the anticipation of the food is as important for controlling our digestive hormones as is the actual sensual experience of the food and the physical experience of the food in our gut. Okay, so, and yes, that's really interesting what Gemma just wrote too, this idea of panic and feeling like you're going to starve can also adversely affect hormones. That is absolutely true. But this is actually a really important thing for patients to understand how much their body is already digesting because of their brain, even before the first food hits their mouth.
We have 2 minutes, so I want to make sure you guys get your CMEs, and we have a bunch of
All right, well,
pieces.
let's stop there because the next exercise is the raisin exercise.
Exactly.
And actually, that's a great reminder. Can we give you guys an assignment for the next meeting? If you could all bring a raisin or some very small, strongly flavored, if you don't like raisins, maybe a grape or a slice of mandarin or something like that to the next session, because we're going to do a mindful exercise together, the Thich Nhat Hanh, John Kabat-Zinn mindful exercise. And I'm going to model that for you because it's a really wonderful exercise to do with your patients. Could you all please, we'll send you a reminder.
We'll send you a reminder, yeah. And then here's your QR code. Now, the survey is going to ask you, not going to link up exactly with the objectives that we set up today, but just answer them as if they were, we're working on the survey stuff. And I put it in the chat so you can quickly link to it. It's the standard survey you did the last time, but we'll be tracking this to figure out the CME piece.